Hi guys, and welcome to Treatments Part 4. This will be our last set of notes on treatments, pretty short unit. And in these notes, we'll be looking at evaluating psychotherapies, so going back a couple days looking at our psychotherapies and how effective they are. And then at the end, looking at preventing psychological disorders. So what can we do to prevent psychological disorders from happening before we have to look at the treatment for them? Okay, so let's start with evaluating psychotherapies, looking at how effective they are. Now, we run into a couple problems when we're evaluating psychotherapy to look at its effectiveness, and those problems are for a couple reasons. So first of all, there is inflation on the end of the reporter. So a lot of psychotherapy results are self-reported. So it's either coming from the client's perception or the clinical or the doctor's perception, right? So at the end of a therapy session or going to therapy for a few months, asking the client their perception of it and asking the clinician their perspective of it is not a good way to measure whether or not something is effective, okay? So results tend to be inflated by those two people. We'll look at some ways to get around that, but some vocab you need to know for this, outside of perception, is regression towards the mean, right? So if we're looking to compare if something traumatic happens in my life and I go to therapy, and after 3 months I report that I feel better, we need to compare that to someone who had something happen and then didn't go to therapy. Okay, so a lot of the times there's waiting list to get treatment for psychological disorders. So when we're looking at comparing patients to outpatients or people that didn't get therapy, we're looking at the regression towards the mean, and mean meaning the average. Okay, so something bad happened, you're depressed. How long does it take you to get back to feeling normal? Something happened in your life that's making you anxious. How long does it take you to get back to normal? Okay, so you compare the regression towards the mean from people that were in therapy versus people that were not in therapy, maybe like on the wait list for therapy. And then you also have inflation of results on the placebo effect. We'll talk about that a couple times on this side. So if I know that therapy is going to, or treatment is going to make me feel better, just by going, I might feel better, right? It might be nothing that the clinician or doctor is doing. It just might be that I'm thinking that I'm doing something that's going to help me. Okay, so the placebo effect can really have a big result on whether or not psychotherapy is effective. Okay, now let's go back to the client. Some reasons why the client's perception of therapy tends to be good. Most people enter therapy during crisis, right? Something bad has happened and they seek out help for it. So time heals a lot. If something happens traumatic in your life, like a crisis, it's hard to compare whether or not it's just time helping you get better or whether it's an actual doctor helping you get better, okay? Another thing that tends to inflate clients' perception of therapy working is that they have to admit it worked because they spent time and money going. So if you tell people that you're going and you spend money, you kind of want to convince yourself that it was helpful. Okay, so they kind of get backed into a corner to admitting that it was a good thing. And they tend to like therapists. Therapists tend to be people that listen to you, that offer solutions, that are friendly. So even if the therapist might not be helping you, just having someone friendly to talk to could be a reason why clients tend to have positive perceptions of their doctors. All right, now let's go down to the clinician's perception. Clinicians or doctors tend to report that therapy works as well. But they tend to hear back from people that benefited from the therapy, and they tend not to hear back from people that didn't benefit. Okay, so if you're constantly hearing how it was good, they might have an inflated perception of their therapy. Okay, so to get around all of this, we use something called outcome research and meta-analysis. And if you've taken stats, you probably know what meta-analysis is. But a meta-analysis research is when I take research from a whole bunch of different studies and they statistically analyze it and they decide whether or not something is working or it's not. Okay, so a lot of the research we have from therapy is effective, and that's what meta-analysis research has shown us. And it's usually, like I said in the last notes, a combination of the biomed therapy and the psychotherapy that makes something that works for that person. Okay, so let's go on to looking at the effectiveness of therapy. In class, we'll talk about the 5 therapies that you should avoid. The pseudosciences we talk about from the beginning of the year, we'll talk about those in class. So you do need to know that there's these 5 therapies that then are considered pseudoscience that aren't considered psychotherapies. But what we have found with evidence-based practice of different therapies, so this is where we're comparing the different therapies, so cognitive, behavioral, humanistic or psychoanalysis, is when we find an effective therapy, it really has these 3 things that come into making the clinical decision making. So patients' values, characteristics, and circumstances combined with the clinician's or the doctor's expertise and available research all come together to make a clinical decision on which practice will work the best. Okay, so that's evidence-based practice, is when you take all of these 3 things to make a good decision for the patient and what type of treatment is best for them. Okay, so evidence-based practice, it's the definition is combining all 3 of these things to make a good clinical decision for the patient on what type of therapy would be best for them. Now, 2 therapies we'll talk about that aren't under the avoided therapies that are actually noted in your book as alternative therapies are EMDR and light exposure. Now, EMDR stands for eye movement desensitization and reprocessing. And this is a type of therapy that has a person relive a traumatic experience or explain it or visualize it while having their eyes move back and forth. All right, and so it is thought to, for some reason, so I put thousands versus thousands. So thousands of people have positive, like they come out of this saying that this is so helpful, it works. And then you also have thousands of people that said it's a sham and a pseudoscience. So it's kind of a, toss-up. But research has shown that so it might work just because you have to relive a traumatic experience and desensitize yourself. So just like getting over a phobia, like thinking about it and becoming more comfortable with it might just be the reason it works. But there's been some research that shows that things like tapping your finger or just reliving that traumatic experience or thinking about it has the same results as moving your eyes rapidly. And another type of alternate therapy is light exposure therapy, and this is used to treat seasonal disorder. So when the time changes, when there starts being less daylight and there starts being colder weather, people a couple things happen. They get to be more tired. They tend to report more depression, seasonal depression, and they tend to gain weight. They become lethargic. And so it's thought that this is like a mild form of depression. It's called seasonal affective disorder, or SAD. You can remember that pretty easily. And so what they do is they actually put them in front of these LED lights for 30 minutes a day to add more light to their surroundings. And people have said that this helps, that actually being in the light for a short amount of time helps them feel less tired, less sad, and less lethargic. Okay, so it's kind of a common sense type of therapy. If you're feeling that way because the light is gone, daylight, then let's just add light to the environment. Okay, some commonalities among all the psychotherapy. So even though we have those 6 different ones I had to compare, and it really depends on the patient and what's best for them, there's some commonalities among all of them. The first of it, and these are outlined in your book, is that there's a hope, that the therapy offers a hope for a group of people that are somehow demoralized, that are depressed, that feel different, that need help. And it lets them believe that they can come out of it. Okay, so no matter what the therapy, there is a belief that that therapy will help you get better, that you have hope to be outside of the situation that you are in. It also can give a new perspective on old thoughts. So no matter the therapy, so cognitive behavioral, you're coming with a new perspective from someone that doesn't know your situations. They're kind of analyzing your situation, and they're giving you new ways to think about it. And you're also just creating a new relationship with someone that you trust and that you can talk to. All right, so no matter what the therapy, those seem to be the commonality among the 3 commonalities among all those different therapies that helps people get better. Now, among cultures, in class we'll look at some similarities and differences tomorrow among cultures and how it changes. And again, we're going to compare the Western culture to the Eastern culture. So talking about the United States, Europe versus Asia and the different cultures they come from and how that affects the therapy and its treatment. Oh my gosh, it's 10:30 and the lights went out. I don't know what's going on. So you need to know this chart. I'm going to turn the lights back on. And this is the type of therapist. Yay. So the type of therapist that you need to know, need to know the difference between a counselor, a clinical psychiatrist or social worker, a clinical psychologist, and a psychiatrist. Don't copy this down right now. Sorry, don't copy this down right now. Hopefully you're listening to me, Anthony. Who else doesn't listen? Brad Davis. So you need to, we'll do this in class and compare it, okay? But you're going to have to compare, leave this chart blank. So counselors, clinical psychologists, and psychiatrists, and we'll do some work with this in class, okay? Now let's talk about some ways we can prevent psychological disorders, and then we'll be done. So here are some therapeutic, non-treatment, non-therapy lifestyle changes that have proven results to improve your mood or improve your well-being and your thoughts about life. And it's called an integrated, so I'm putting all together, biopsychosocial system. So you're using biology, your thoughts, and your culture to change your lifestyle somehow. So here are some proven things that help you feel better about yourself. Aerobic exercise, absolutely. Endorphins, just feeling better about being active. Adequate amounts of sleep. People who don't get enough sleep have go into different types of states, most of which depression, but even bordering on psychosis. So sleep loss, not getting enough sleep can make you literally feel crazy and decrease your brain functions. Light exposure. So because there's some evidence that shows that that works, just getting outside of your video games or inside TV and getting into the sunlight has been shown to have a therapeutic effect. Social connection, so we talked about the making friends and how that helps you feel better. And then nutritional supplements and anti-rumination we can look at in class. But those are looking at the things that you eat that make you feel better. So this is like the biology and how that might affect your mood. And then your very last slide on preventing psychological disorders looks at resilience. And here's the definition of resilience. So if I'm looking at preventing psychological disorders, the belief of resilience or knowing that people have strengths that help them recover, and that people have different types of resilience, can help prevent psychological disorders, meaning that if something traumatic happens like 9/11, we'll read about this in your book, and looking at how different people react to 9/11, we'll talk about their resilience levels and how that affects how they reacted to the situation, and how that helped them prevent things like depression and anxiety about future occurrences. Okay, so that's the end of our treatments. This is just looking at preventing and comparing. And in class tomorrow, we'll add some of those. I know a lot of you are gone tomorrow, so you can do your own tutorial at home in your book. But I will talk to you guys later. Bye.